The foundation of physical medicine and rehabilitation billing is structurally collapsing under modern payer rules. Across the broader healthcare industry, initial claim denials are accelerating, hitting an 11.8% failure rate in 2024. Compared to that baseline, CMS data shows comprehensive outpatient rehab facilities face a towering 47.4% improper payment rate. As this chart highlights, nearly half of all claims fail. It isn't fraud. Insufficient documentation accounts for almost 90% of those errors. Over 40% of providers now experience denial rates exceeding 10%. This is a systemic tightening of payer rules, not an isolated glitch in a few clinics. PM&R clinics are bleeding catastrophic amounts of revenue, not from poor clinical care, but from participating in a uniquely hostile administrative framework. The root of this failure rate lies in the mechanics of a PM&R visit. Unlike general practice billing, physical medicine relies heavily on time-based CPT codes. That creates an immense operational burden. Exact minute-by-minute documentation and flawless unit calculations are required for every single session. A single patient visit splits into multiple branching pathways for different interventions. Each branch demands a matched code and specific modifier. Watch what happens with a single authorization error. One tracking bottleneck nullifies the entire sequence of connected claims. Add in payer-specific medical necessity rules, and one minor gap in a clinical note triggers an automatic denial on an otherwise perfectly clean claim. The PM&R clinical note functions as a mathematically rigid financial document, where close enough equals zero reimbursement. The initial rejection is only the beginning of the financial damage. The real destruction to the P&L occurs during the rework phase. Every single denied claim costs the practice between $25 and $30.50 just to touch a second time. This funnel tracks those rejected claims. 100% enter the top, but only a thin 35% stream is ever fixed and successfully resubmitted. The remaining 65% simply leak out of the system, abandoned as permanent write-offs. For the few claims that are recovered, commercial payer reimbursement delays range from 42 to 137 days, completely freezing expected cash flow. Claims left unworked past 60 days experience a severe drop in recovery probability, creating a compounding backlog that overwhelms administrative staff. In the PM&R environment, an initial denial represents a statistically probable total loss that actively drains operational capital. Practice owners often keep billing in-house because seeing staff at a desk provides a psychological sense of financial control. This graphic breaks down the true loaded cost of one in-house billing employee. Stacking the median salary with benefits, payroll taxes, and paid time off brings the actual expense to between $55,000 and $75,000 annually. That assumes absolute stability. But when that in-house biller inevitably leaves, the revenue cycle enters a staffing spiral. Recruiting and training a new certified coder drops a heavy turnover penalty onto the ledger, pushing the total cost well over $100,000. Training that new hire takes 60 to 90 days. During that operational gap, billing accuracy plummets and accounts receivable days push past 45. Overwhelmed staff spend their time appealing past denials rather than ensuring current claims go out clean, guaranteeing a future wave of rejections. The in-house control model actually exposes a practice to catastrophic single point of failure risk, mathematically guaranteeing high costs and low operational resilience. Manual billing teams face an external environment defined by rapidly changing, highly contradictory payer requirements. Documentation that secures approval at one insurance carrier will automatically trigger a denial at another for the exact same clinical service. It is completely impossible for a small in-house staff to stay ahead of algorithmically updated rule changes across a complex payer mix. Poor billing practices and revenue leakage from these exact eligibility and coding mistakes currently cost the U.S. healthcare system $125 billion every year. Fighting algorithmic payer denials with manual human labor is a structurally unwinnable war. Smart PM&R practices are stepping completely away from the brute force in-house model. They are adopting a production model, characterized by combining credentialed human specialists with AI-augmented workflow tools. This is the first defensive line. Automated audits use pattern recognition to scan digital documents, flagging documentation gaps and modifier mismatches before submission. The operational layer then uses predictive workload management to route claims into organized lanes based on complexity, preventing backlogs. This precise sorting frees AAPC and AIMA credentialed experts to focus exclusively on judgment-based decisions and complex accounts receivable recovery. Modern RCM systems use AI to enforce total compliance on routine errors, reserving human intelligence for high-level strategy and complex recovery. The economic difference between these two systems is absolute. Compare the chaotic $100,000 risk of an in-house biller on the left against the predictable, fixed infrastructure of the outsourced production model on the right. This model specifically targets the recovery of the 65% of claims that standard practices write off, instantly injecting lost capital back into the clinic. It mandates strict workflow advantages, like verifying insurance eligibility before appointments and running systematic root cause denial reports every month. The 11.8% industry denial rate is rising, and outdated manual processes will not survive the coming algorithmic payer tightening. PM&R owners must stop running shadow billing companies and adopt the technology required to finally get paid for the complex medicine they practice.